Hello everyone, this is the next video, and in this one I'm going to talk about drug prescribing in dentistry. Now this topic generally is mostly just rote learning, but what I'm going to try and do is give some key points so that it makes it easier for you to remember what medications are taken for which condition. There's some pointers. This video does not cover absolutely everything you need to know. However, it does cover most topics that come more commonly in the exam, and it does not cover anxiety and dry mouth and caries. Anxiety, we give diazepam, and dry mouth and caries. Basically, if you know the delivering better oral health part, you should be able to do the caries and the dry mouth part of this. Now, before I get started on this, there has been a change in the guidelines, and so I've incorporated that. If you have any suggestions or any comments on how it's different from what I've mentioned in this video, please do let me know. But from what I could gather from the guidelines, the Scottish guidelines, these are the guidelines presented. Now, in this guideline, they've mentioned several times about how local measures are more important in treating any condition as opposed to the systemic measures, which would be medications. Now, in any kind of condition, we have to first institute local measures, and then if, for example, the patient is having any kind of systemic signs, like in case of abscess, if there's swelling that's persistent, cellulitis, fever, malaise, these would mean that we should give antibiotics. However, if it's a local infection, for example, in abscesses, as I'm going to mention just now, we're just going to drain the infection. Now, certain drug interactions, very important for you to remember, are that firstly, NSAIDs, carbamazepines, and fungal medications like azoles, and metronidazole and macrolides, these all interact with warfarin, and this would obviously then NSAIDs include ibuprofen and aspirin. So don't give these medications if a patient's on warfarin. In OSCEs, they will give you a scenario possibly in which the patient is either pregnant, is on warfarin, so you need to keep in mind these things before you prescribe the medication. So for warfarin patients, we're not going to give any ibuprofen, any aspirin, any carbamazepine. Carbamazepine is something that we prescribe for trigeminal neuralgia. Any fluconazole or meconazole, or any metronidazole. We can prescribe amoxicillin for warfarin patients. When it comes to statin drugs, we have to be careful not to prescribe any azole drugs like fluconazole, meconazole, or clarithromycin. Coming to asthmatic patients, we have to make sure we don't give any NSAIDs because that may worsen the asthma. So for asthmatics, if there's analgesia that we're worried about, and we want to give something for the pain, we're going to give paracetamol. So now, coming to abscess. In case of abscess, first of all, of course, we have to try and drain the infection. And draining the infection can be done in two ways, in either extraction of the tooth, or we can drain through the tooth, that's the pulp. So if we can do those things, that's what we should do rather than give any antibiotic. So drain the infection first. However, if the abscess is causing systemic signs, like I mentioned before, then we're going to give amoxicillin, 500 milligrams capsule, 1 capsule, 3 times a day for 5 days. Now remember, in abscess conditions, both metronidazole and amoxicillin that we're giving are given for 5 days. Okay, now coming to metronidazole, we give 200 milligrams of the tablet, 1 tablet, 3 times a day for 5 days. You can of course work out how many tablets that is. If we're giving 1 tablet 3 times a day for 5 days, that makes it 15 tablets. Now, in case the patient, now amoxicillin is the first line drug when it comes to abscesses. If the patient is allergic to penicillins, we're going to give metronidazole. Now, what happens if the patient is allergic to penicillin and the patient's on warfarin? Remember, we can't give metronidazole for patients on warfarin. In that case, we're going to give clarithromycin. And for clarithromycin, we're going to have more days of a drug treatment. So it's going to be 250 milligrams, 1 tablet, twice a day for 7 days. So just remember that for abscess generally, if it's a patient who does not have any other conditions that we need to keep in mind when prescribing, it's just going to be 5 days for abscess. Even if it's metronidazole or amoxicillin, it's 5 days. However, if we're giving clarithromycin, that's got to be 7 days. Now coming to NUG and pericoronitis. For necrotizing ulcerative gingivitis or periodontitis, and for pericoronitis, the drug regimen is the same. First of all, we're going to do our local treatment. For patients with necrotizing ulcerative gingivitis or periodontitis, we're going to try and debride supra and subgingivally if the patient can tolerate the pain. Usually the patients are in a lot of pain, so they can't really tolerate the pain. If they can, try to do it supragingivally at least. If they can't tolerate the pain, then we have to institute medication straight away. So that's the local measures for NUG. Whereas for pericoronitis, we're going to first irrigate and debride. And if we see, for example, any systemic signs, we're going to give medications. Now for NUG and pericoronitis, it's the reverse. So the drug of choice is metronidazole in this case. And then it's amoxicillin. Now remember, the dosage of amoxicillin and metronidazole stays the same. It's just the number of days the treatment is carried over that's different. So remember, for abscess it was 5 days, and for pericoronitis and NUG it's 3 days. Okay, so we're going to prescribe fewer number of capsules and tablets. However, the dose of amoxicillin and metronidazole, as you saw earlier, it was 200 for metronidazole, 500 for amoxicillin. That's going to stay the same. We just give 1 capsule thrice a day. If we're giving these medications, that's how we give them. The only thing we change is the number of days we give the treatment over. So again, for abscess, it's 5 days, and for NUG and pericoronitis, it's 3 days. So I'm just going to keep repeating this as we go along, and if we have the same medication, just so it's easier for you to remember. Now coming to sinusitis. Now sinusitis is something that usually limits itself within 2.5 weeks. Now, if for example if there's any discharge that continues over weeks, if there's any systemic signs, we're going to give more than just the advice to inhale steam. The medications that we can give are ephedrine nasal drops, 0.5%. We give 1 drop per nostril 3 times a day, and we give 10 mils of it. Again, amoxicillin. Now again, the dose is the same. It's 500 milligrams, 1 capsule 3 times a day. The difference, however, is that in sinusitis, we give a longer course of the drug. We give 7 days. So of course, the number of capsules is also increased. It's 21 instead now. Now, if for example the patient is allergic to doxycycline, we're going to give allergic to penicillins, we're going to prescribe doxycycline. Doxycycline capsule can be given as 100 milligrams. So the way that this is the 1 capsule that's kind of given differently. We just give 2 capsules on the first day, and then the second day, 3rd day, 4th day, 5th day, and 6th day, it's given as 1 capsule. So this is also done over 7 days. It's just that the first day it's 2 capsules, the next 6 days is 1 capsule each. Remember that we can't give doxycycline in pregnant women. We can give amoxicillin, just not doxycycline. So just to recap the number of days, for abscess, this was 7 days. This was 5 days, sorry. For abscess, we carried out the treatment for 5 days. For NUG and pericoronitis, we carried out the treatment with metronidazole and amoxicillin for 3 days. And for sinusitis, it was longer, for 7 days. Remember, in sinusitis, we don't give metronidazole. We give either amoxicillin And if not amoxicillin, then doxycycline, no metronidazole.